Good evening, good afternoon, and good morning. I am Dr. Sandeep here from India, introducing you to today's webinar by Dr. Maurizio Serafini from Italy. And before I introduce him, I would like to talk because I'm back after almost 6 months back into the business because I was undergoing a lot of trouble. There's a lot of difficulties we were facing in India. As you know, we are undergoing the second wave of COVID-19 pandemic in India. It's bad situation. I would like to talk about the doctors uniting the effort by our team and especially Dr. Kianor Shah and the team, which includes me and many more people. We are still going on for webinars, and as you see below the logo, the QR code. Those who are interested in coming up with their products, which could be related to medicine, pharmacy, dentistry, philosophy, optometry, chiropractic, they can apply for that. And then they get the confirmation and they can come up for the webinars. But if you see on my right side, this is this one, the one I'm pointing right now. This QR code is for the nominations for this year, and let me tell you, we have stopped the nomination for dentistry, it's full. But people from medicine, pharmacy, philosophy, optometry, and chiropractic, they can still apply for their nominations for this year. And now I will come on the introduction of Dr. Maurizio Serafini. And let me tell you, he's the first medicine guy, MD guy, who is here with us onto the Doctors Uniting platform. And let me tell you, he was born in Italy on 24th of May, 1955. And he works in Chieti. I hope I pronounced rightly the word for the town, Chieti. In 1974, he graduated in dental technology and worked for 10 years as technician. In the meantime, after his military service, he enrolled into the Faculty of Medicine and Surgery, graduating in 1985. And since he got his degree, he has been dealing with implantology, with a path that you can read into his CV. So without taking much of my time, your time, and everybody's time all around the world, I will pass on it to Dr. Maurizio for today's webinar, where he'll be talking about PRP. At the end of the presentation, we will be discussing few things about the difference between PRP, the first generation growth factors, and PRF, the second generation growth factors. So now to Dr. Maurizio.
It's okay, the presentation? It's okay?
Yeah, it is fine. It is fine, Dr. Maurizio. You can start with the presentation.
Thank you. Good morning, someone. Thanks a lot for the brilliant presentation, Dr. Sandeep Singh. I hope you enjoyed this lecture since you are a profound expert of growth factor and regeneration. Thanks to Dr. Pavel Krastev that gave me this opportunity. I'm very honored to have named at the top 100 doctor in the world 2022 and to participate at the Global Summit. Perché non va? Okay, so I teach at master degree courses in Aldo Moro University in Bari, in particular implantology and regeneration. I deal of regeneration and advanced implantology for over 35 years ago, and since 2000, in particular with growth factors, PRP. Above all, the severe deficit of horizontal and vertical bone atrophy. This is the Paris University building. So, and from these years, also the master in Berlin. Thanks at Professor Ioannis, we counted me among the best professors in this prestigious university. Today, I will talk about the growth factor and bone regeneration. My mantra is first neonatology and after implantology, then bone regeneration. I know that talking about regeneration nowadays is anachronistic, long healing time, higher cost for people like to wait a long time. So it was outclassed by other systematic assets, zygomatic implant, short implant, all on 4, few implant for large, but every systematic has its problem or disasters, as I show in this series of slides. Zygomatic implants taken from Facebook, clinical case of Dr. Sante Vassallo. The zygomatic implants, which involves the use of long implants inserted from the basal bone crest to the zygomatic bone near the ocular orbit of the patient. The surgery is very, very invasive and require adequate training and surgical experience, and it's belong to the maxillosurgeon. Short implant. This clinical case isn't mine, but the patient has lost the short implants 3.6 and 4.6. Here, we have a double unfavorable condition. The collar isn't shine, but it can't because it's a short implant and the low hygiene. The plaque, and the ratio between the crown and roots has an unfavorable level. Full arch, few implant, disasters. The doctor Abulai wonders why he has lost this job to his best friend. He says, I have used Nobel Active. He made an immediate load, give a torque of 40, 50 Newton with ESQ 70 and more. Okay. But as is being said, if professional oral hygiene was regular, because I saw the plaque around the implant. If the bone was a consistent at least 83, and if it was not the case to insert more implant to condense the bone, because I saw the great Canty level. Certainly, this one is only the supposition, since the clinical case is not supported by X-ray images. And all on 4. Do you have any idea how much food remain under the prosthesis? Before proposing this one, ask you, would wear it? Taken from Facebook. Well, most of these artifacts, bar and counter bar, are made of steel. The consequence, metallic dualism with titanium implants and therefore galvanic phenomenon. With what consequence for the implant? When they go to the airport, they would do well to have an X-ray when passing under the metal detector. And daily per-implant hygiene. How does it happen? In order to not to have halitosis? And what if one day she needs to have a MRI scan? What do you do? Take everything apart and we'll go around without teeth? Don't mention it, they screw it. The patient face forced to go to the dentist at least once a month to have everything removed and to do the hygiene, cost on cost. Otherwise, these are the consequence. How much food we stop here between the fornix and the prosthesis? And with what consequence? This one is disaster. This one is the consequence. Disasters. For me, in dentistry, bone regeneration represents a crucial therapeutic aspect for a complete, balanced, aesthetic, and functional recovery. Over the year, various techniques have been proposed and different types of materials, autologous and heterologous, have been subject of a critical review through the clinical trials and isologic examination. The continuous research in optimum bone substitution materials has led to the introduction of many other materials, has led to material in order to find the best one. However, until today, none of the material studied can be considered or definite as the perfect material, since none are limited or defect-free. The need to overcome problems such as long recovery time, high cost for both clinician and patient, cross-infection risk, led to developing new techniques based on growth factor use potential through PRP and PRF obtained in the clinic before the surgical procedure. Aim of the study is to demonstrate the influence of using growth factor in bone regeneration in advanced implantology cases, such as severe bone defect that involve maxillary and mandibular. The preliminary study of complex cases through CAT scan and computer implant software is crucial for an accurate preoperative evaluation of the anatomic limitation and facilities preoperative planning of therapeutic strategy. It's very, very easy to do implantology in this situation. Large thickness of the bone, quintals of bone. But the sore notes come when we are faced with these other situations, when we have the knife blade crest, where the two corticals are unit or fused together, and the thickness is resulted of 1 millimeter, 2 millimeters. In December 2020, published on the International Journal of Stem Cell Research, the clinical case you will see below. White crest, split crest, slim crest, 2 millimeter wide and 13 in 8. Venous blonde and PRP, split crest with vertical release in 2004. Animal bone graft and PRP, note how much the horizontal dimension I have increased. The other is, the other implants were located the years before. X-ray control are 14 years later for the split crest and 15 years for the plate. In November 2018, the 3D showed the perfect condition of the implants, so the blade 1.4, 1.5, and the horizontal diameter from 2 millimeters to 5.5. 14 years later, excellent yield also for the plate. Another publication on Women's Day, 8 March 2021, the clinical case you will see below on International Journal of Advanced Biochemistry. Well, chronic periodontal disease, poor oral hygiene, stage 4, a grade C. The image speaks alone, occlusal view, lower, left, and right. Well, 1 week after oral hygiene. The planning, 3D view, left, right, and 3D X-ray in 3D. Venous blood, PRP, and left side slim crest. Slim crest, mucoperiosteal flap, and height descends also 13 millimeters in 2.3. Split crest, implants are located without load, and grafting and biologic membrane in situ. The biologic membrane is made in PRF. The other side, extraction, one-to-one implants are inserted, abutment mounted, and palatal view. Post-surgical control, immediate loading, and second surgery in the jaw. 3D left and right, clinic situation, home plans, one-to-one system, abutment and more for immediate load, post-surgical control. Temporary prosthesis placement in situ, and post-surgery control for 2.3 after 6 months from regeneration. Occlusal view after healing of soft mucosa, and first neonatology. Diagnostic WhatsApp, try-in, proof of the labial rima, occlusal contact, definitive work in zirconia ceramic. One-to-one system. Definitely in situ, occlusal view, contact incisal, left side, right side, and first and after. Here's my and my satisfaction. In November 2020, another publication in International Journal of Stem Cells of the clinical case they may above illustrate. Several vertical bone resorbament for granuloma, where the patient has lost more palatal bone. More palatal bone for the granuloma. The image 3D, the arrow exhibit the oro-antral communication. We have only the gum between the roots. And after the toilet of the surgical site, we know the prolapse of snyderal membrane. 2 implants was located and only fibrina sponge embedded with PRP between the screw. Look, the implants 1.6 has the vacuum around, and it's supported by only a bone brace. Only a bone brace. Only a bone brace. No bone graft inside the sinus, only fibrina sponge imbibing with PRP. After 6 months later, note how many new bone around the implant. 1.6, 1.7, and 1:1 definite crown in ceramic zirconia. Another similar case where we have only a bone brace, root fracture and vestibular bone lost. The clinic situation, and the gray color is the transparency. The gray color is the transparency of the sinus cavity due the low bone thickness of the sinus floor. In fact, few millimeters in it. Implants are located. This implant has a great grip around three walls. And this situation has allowed me the immediate load because the patient had to leave for Belarus. Scaffold, animal bone, and PRP. Control at 8 years later, 2017. The crown up, the crowns was made by me, and the other ones be made in Belarus. No, the no perfect profile, but we have the perfect also integration. A few days ago, another publication about the clinical case you will see below. The Caucasic family patient of 50 years old with marked severe osteoporosis. We have only 3.67 millimeters in height and wide at the base 4.83 wide. This clinical case was the most difficult case I've treated, vertical and horizontal atrophy in a patient with severe osteopenia. The mock mineral bone densitometry, coxofemoral and vertebral column show that this score and zeta score are all negative. Diagnosis severe osteoporosis. Right side, the image speak for themselves. I only had a triangle of bone available. Osteotomy with surgical osteotomies and the surgical hammer, because with other system, cutters, piezo, we would have depleted the bone, and the bone I haven't in this clinical case. I must to say the tissue as possible. Bone graft with PRP, and left side slim crest with the bone retraction. This condition is much more difficult to make the split crest because the ostomy line must follow the shape of the bone. Totally different is making a liner cut. Left side, the implants are located bone graft with PRP, post-surgical checkup, and in order to not weaken the bone around the implants, I choose to remove the roots 2.6 at a later time. First, signatology, diagnostics works. Correction, green works. Definitive in zirconia ceramica, 1:1 system, and case finished with occlusal view, air smile, and my great satisfaction. My great satisfaction. X control at 8 years later. The 2.6 was replaced 8 months later, the regeneration. Here I have the buff atrophy, 0 bone. zero bone. The yellow arrow shows the zero bone for the granuloma, zero bone, zero bone, zero bone. The clinic situation after extraction, the arrow shows the oral tract communication and the black arrow, the mucosa height, animal bone, PRP scaffold. Graft and biologic membrane, post-surgical checkup, right side, the same situation, membrane, scaffold, graft, and post-surgical checkup. Control a 5 months later, left side, and 4 months right side. Healing, X-ray control at 9 months right side and 8 months left side. Note the ossifications nucleus. And I start from 0 bone. I have increased it in 8, also 7 millimeters and wide 6.2. 0 bone. And the planning, the cut right side, and we have increased it 9.7 millimeters in 8 and wide 6.5 from 0 bone. The planning, first neonatology, and in this clinical case, I used the particular implants with particular shape are implants designed, patented, and manufactured by me, created to perform the crestal sinus lift without the aid of the osteotomies and surgical hammer. I published in February 2021 on International Journal of Stem Cell Research. You will see a video later. Right side, implants are located, and left side, we have the retraction, but no problem. In this peak is a beautiful peak. After mucopreosteal flap, we know the retraction, the basal bone, and rhinate bone. There is the line marked between the basal bone and rhinate bone. Beautiful, beautiful peak. Autologous bone graft taken from milling and, post-surgical checkup. Colleagues, peers, here we have had 0 bone in 8 and note how much bone I have regenerated. Right side, left side, healing, RX control 7 months later, and right side, the loading, X-ray control 12 months, 4 months after the loading. Perfect. Note how much bone around and up the implant. 0 bone. Another publication on Journal of Advanced Biochemistry well, this one is the clinical case. 3D image, clinic situation, and after the mucopreosteal flap, I have the vestibular bone, yellow arrow, palatal bone, black arrow, and the middle nothing. Then horizontal deficit. Animal bone, PRP, calcium gluconate, membrane, biologic membrane, scaffold grafting, biologic membrane are located, and suture. At control at 12 months later. Soft tissue healing, but what do you think is down here? What do you think? More bone, no bone, less bone, only mucosa fibrosis? What? What do you think? Excellent regeneration. And there's no need for biopsy to understand it's a bone. More bone. Well, usually, those who do regeneration know that a large part of grafted bone is reabsorbed. A good 50–60%, because here we have all the grafted volume, because the bone cells homeostasis is regulated by by loss of biomolecules produced by the immune system, by platelet and by cells from the osteogenic lineage. Some of these substances do not seem to be able to act individually, but in association with systematic hormones, as well as parathormone, calcitonina, vitamin D, and the PDFG, the platelet-derived growth factor, is mainly involved in the mitotic activity of tissue repairing process, and like beta TGF, the transforming growth factors, is involved in angiogenesis and osteogenesis, and is a chemotatic booster for fibroblasts and other cells implicated in wound healing. In vitro and vivo studies have proven that the use of platelet growth factor, PRP and PRF, allows a faster healing and mineralization of the graft equal to half of the time, and the bone density improvement between 50–30, speeding mitogenesis and angiogenesis along with macrophages activation. The amount of the PDGF for million platelet is 0.06 milligram, approximately 1,200 PDGF molecules per single platelet. Growth factor placement graft PRP by Robert Marks. In vitro studies show that the growth factor-like PDGF are secreted by platelets through a degranulation process with behind whiting few minutes after the contact with the receiving surface. Once degranulated, the platelets are no more source of growth factors, but the difference of the pressure gradients between the tissue hypoxia 0.3 and 5 millimeter mercury and of the surgical side, then compared to the 44–45 millimeter mercury of the healthy tissues that surround it, attracts and increases the concentration of monocytes and macrophages, which have a rapid replication and very efficient growth factor release, explaining how they lead the second phase of bone regeneration, promoting angiogenesis already in third day. I used to impregnate the implant surface with PRP in their blister, autologous bone, PRP and biologic membrane. Implants are located and membrane in situ, post-surgical checkup, the cut control at 6 months later. We have the solution of continuity for AIDS extraction 35 years ago. Note the affected bone aids have the rounded edges. Cut control at 24 months. Perfect. Perfect. This one is the is a very, very difficult case. Caucasic femur of 49 years old. Planning cut only 2.1 millimeter in 8. 2.1 millimeter. Right side. And in left side, they have 0 bone. In the middle, 0 bone. 0 bone in the middle. Wide 6.5 and palatal bone 2.1. Palatal view, 1-to-1 implants with immediate loading. First in neonatology and then implantology, my mantra. Right side, 1-to-1 post-extractive implant. Left side, the same. A biologic membrane. And right side and left side, placed. Post-surgical checkup. Immediate loading, temporary crown. And at the first surgery, I had the wrong account. I had inserted one less implant and the patient didn't want other solution than 1-to-1 with all single tooth. After 2 months, I had to insert another implant as a contract, no problem. And this time I have 2.6 millimeter in 8. The planning, PRP, mucoperiosteal flap, only the invitation with the drill. Moving. The fibrina sponge imbibing with PRP inside the sinus. The PRF inside the sinus. PRF. Note the PRF around the implant surface because I weight the implant in its blister with PRP. And despite the low bone in 8, have you note how much grip is obtained with this implant? And note the eyes of the patient. Well, remember, the PRP inside the sinus, the sponge dry, the implants are located, and post-surgical checkup for 1.6 and 50 days for the others. Well, 50 days. Have you noted how much bone up and around the implants? We have had half millimeter in 8 left side, and right side X-ray control same mouth later, and 5 mouths for 1.6. Well, the arrow, the red arrow was the old pavement of the sinus, and the yellow arrow is the new pavement. And note how much bone on the implant. 0 bone, 2.1 bone. Now we have 10 bone in 8. X control at 14 months and 12 months for 1.6. Now we have the young bone, mature bone. Well, the healing of soft tissue and definitive in zirconia ceramic one-to-one system. Occlusal view and air smile, and my great satisfaction. Thank you for your attention and patience. Thank you.
Thank you so much, Dr. Maurizio, for the wonderful presentation. Just a minute. You beautifully explained the difference which people would like to know more. I don't think I have any questions right now from the viewers, but I would like to ask you that what is the basic difference between a PRP and a PRF, which is known as second generation growth factors?
Yes, the PRP, we have the growth factor intact. When the platelet is cracked, we have the PRP free on the sinus, on the site, surgery site, and the PRF, we have the coagulation, cioè the PRP plus gluconate, calcium gluconate, we have the PRF.
Okay. As many people know that PRP sometimes to stop the coagulation of the blood, bovine anticoagulants are used to make it into a liquid form. They maintain the liquid form.
Inside the sinus?
Yeah, inside the tube.
Inside the sinus, yes.
Yeah, so they use
the blister, inside the blister.
Yeah.
Because for to impregnate the implant surface.
Okay. But many people have reported some kind of allergies into the human beings when you are using the PRP, because I have seen use of PRP is more into trichology, where they are implanting or they are treating the hair growth,
Yes, yes,
because
yes,
they maintain
yes,
that liquid form.
yes.
Yeah. So what do you have to say on to these allergies which happens due to the bovine anticoagulant? So do you use the bovine anticoagulant still, or you use something else?
No, no, sempre, always, sempre. I use sempre the PRP for
Okay.
all patients because the patient, if the patient hasn't the coagulation problem, I use always the PRP.
Because I have been using the second generation growth factors, which is PRF, by Professor Shukroon, and I use the IPRF form, the injectable PRF form, to create this
But
sticky
the
bone.
PRF, the growth factor has just is finished. There isn't in PRF the growth factor because we have had the coagulation
Mhm. We allow
and
the
yes, and we haven't the growth factor. We have
okay,
only the coagulation. I use the PRF only for the biologic membrane.
okay. And what do you think about this the sticky bone formation, where you use the injectable form, the liquid form, which generates the fibrin to hold the biomaterial like xenograft or any kind of graft material? Because then we it coagulates and make the graft material into a sticky format so that you can maneuver,
No, I
manipulate.
use the granulated graft. No, no, no sticks, no blocks, no, only granulation. The granulation between 40, 70 micron
Okay.
because
No,
it's
what
the
I'm
mix,
trying to,
cortical and you mix cortical and sponge bone,
yeah,
animal
corticocancellous.
bone, animal bone.
Yeah, but when we are using the animal bone, the bovine bone
Animal
or the
bone.
porcine, yeah, the porcine bone, how to make it, coagulate it and make it into a sticky format. So that's why I have been using IPRF and I get pretty good results with that. So I just want you to put some
I
light onto
use
this.
I use the PRP plus calcium gluconate. The calcium
Okay,
gluconate uh, cracked the platelet, the growth factor was released, and we have the coagulation
okay,
with calcium
so,
gluconate.
okay, okay. So now I
Okay?
understand that you use calcium gluconate to make
Yes,
it coagulate
yes,
the
yes,
the liquid form.
yes, yes, the liquid form.
Okay, okay. So thank you so much, Dr. Maurizio, for your enlightenment onto PRP in bone regeneration. And I would like to tell my viewers that as a director for Sehaj Dental Academy, which is a partner for doctors uniting the organization which we have in California. It's a collaboration with Sahaj Dental Academy, and we work together in India and for all around the world. And we have got a lot of good
I have had the
webinars
International
going on.
Congress in Loni
Yeah,
in India in 2018. The International Congress in Loni, Pravara.
yeah. So you were there? You were there, Dr.
Yes.
Maurizio?
Yes.
Oh, that's wonderful. I was supposed to come there, but I think Professor from Greece, Dr. I just forgot the name. He was also there from who is the dean of the Berlin School, and he is our into the board of directors and regents for Doctors Uniting. So it was wonderful having you here with us. And with this, I would like to say thanks again to you and all our viewers who are watching you and listening to you. Thank you so much. And namaste from India.
Thank you. Thank you
Yeah.
for all. Thank you.
Thank you.